paper presentation right now. May I please invite our convener, Dr. Jayesh Nayak, to please approach. And our chairperson, Dr. Gaurav Waghmare, to please approach the front and have a seat. I'd like to invite our first speaker, Dr. H.R. Jhunjhunwala, to speak about his topic, an innovation technique for revision cup.
Good afternoon. Thank you for the Bombay Orthopaedic Society to allow me this presentation. Thank you. This is absolutely an innovative technique, cup into cup, for revision cup. This is an example of a 52-year-old male underwent Austin Moore orthoplasty for fracture neck femur in 1994 in Madhya Pradesh. Austin Moore failed in 4 years. So in 1998, it was converted into a cemented THR. That also failed in 5 years. Peri-implant osteolysis, you can see here. Osteolysis, and so revision uncemented long stem, because there was a lot of osteolysis here, the revision was used the long stem processes with uncemented multi-hole socket, because we could fix up with multiple screws. That was done in 2003. And for 17 years, it was uneventful recovery. In April 2020, he presented with pain, limping gait, difficulty in standing from a sitting position, and on clinical examination, pain on active and terminal passive movements of the hip. Radiologically, cup looked stable and stem showed some proximal osteolysis. No systemic complaints, CBC, ESR, CRP, all levels were normal limits. And then we decided to open the joint, and we found that the cup, the stem was found to be stable with good distal hold. Poly was worn out here, and there was a fracture. The metal shell for this cup was very stable. Frozen section, no infection. With tribological advancement, most of the companies modified their design of the poly over the years, and therefore there was a dilemma what to do now. This poly was not available. So question was whether to revise the whole assembly, shell as well as the poly, or only do the poly. So the bailout was difficult to have an option. In view of the extensive nature of the surgery, also to prevent the blood and the bone loss, as the patient is now 78 years and he had comorbidity also, we tried to bail out with a simple and innovative technique of the cup into cup. From the cup, the shell, this is the shell of multi-hole, we have removed the cup, put the cement and put a cemented cup and fixed it up. And cementation of the elite poly 47 millimeter size, well fixed and stable, other outer cementless shell of the 54. This shell was 54, this was 47, so there was about 3 millimeter cement around the cup. Head was changed with a longer neck to get a better stability of the hip. And post-operative patient walking pain-free with a stick support on the day 5. This is 2.5 years follow-up. Patient is walking about without any aid, and he could sit and stand very well without pain. The stem was same. Gradually this osteolytic area in the stem also healed up, and the cup was doing very well. The highlights of this technique is, this technique has not been described in the literature at all. It is a viable, cost-effective, better alternative to the conventional revision when only poly has to be changed. Same company's poly is not available. This cup into cup innovative technique shortens the operative time, reduces blood and bone loss, and overall perioperative morbidity. Thank you very much.
Thank you, sir, for your wonderful talk. May I invite Dr. Pooja Baranwal for functional outcomes of surgical management of lumbar canal stenosis?
We take questions now or later on?
Once. Questions once this is over, or we can take it right now also, sir. No problem. Any questions for sir?
Sir, I have a question. What is the role of MRI to diagnose aseptic loosening? Because in X-ray we could see that there was some osteolysis around the femoral stem, but clinically the stem was well fixed. So any role of preoperative MRI to see any osteolysis?
Yeah, you can see the osteolysis as such also in the plain X-ray. Yeah. Plus CT scan we have done which shows osteolysis in the proximal part, but there was no osteolysis in the distal part, and therefore we took it that the stem is very stable, and even when we opened up there was no instability of the stem at all.
Okay. And sir, is there any role of teriparatide in cases of suspected aseptic loosening or osteolysis?
Sorry, I could not get it.
Teriparatide injection, parathyroid hormone, in case of aseptic loosening, suspected joint pain after, TTHR.
There was joint pain while sitting and walking, which has, after the poly was changed, the cup into cup position was given. Okay. There was no pain at all. After. He could sit, he could walk, he could do everything.
Okay. Thank you, sir.
Thank you.
Thank you, sir.
Good afternoon, everybody. My topic is functional outcome of surgical management of lumbar canal stenosis. My study compares the role of various factors, including duration of symptoms, instability, and neurodeficit present in patients in affecting the outcome of surgical management via various modalities. For my study, I have used JOA score, which is basically Japanese Orthopaedic Association score for lumbar spine. It involves subjective symptoms, objective findings, and affection of daily activities. So this is the thing that I found most useful for my study. My study is a retrospective observational study that was done in a single tertiary care center with a follow-up duration of 18 months. Patients with age more than 40 years with claudication distance less than 200 meters were included. Patient with any prior traumatic vertebral injury, any prior lumbar spine surgery, or radiological LCS with no clinical symptoms were excluded from the study. 30 patients were selected randomly and were preoperatively assessed based on JOA score questionnaire. They were operated via various modalities suiting the patient based on their clinico-radiological status, and patients were evaluated post-operatively at 1, 6 and 12 months, and then their JOA score was calculated at each time. Patients were then compared on the recovery of quality of life based on recovery rate based on various factors including instability, duration of symptoms and neurological deficit. Recovery rate was calculated based on the formula using difference between post-op and pre-op JOA score, and patients were categorized into 4 groups including excellent, good, fair and poor. The modalities of surgeries included laminectomy, discectomy, laminectomy with or without discectomy, with or without PLIF with instrumentation. I would like to discuss a few cases that were done for the study. First is a 60-year-old female with back pain more than leg pain for more than 12 months. Instability was present. The patient had no neurological deficit. MRI showed significant canal compression and preoperative JOA score was 12. Patient was operated using interbody fusion with instrumentation using rods and screws, and was follow-up X-ray of 12 months as shown. Post-operative JOA score was 26 and the recovery rate as calculated by the formula was 82.35, which was falling in the good category. This is my second case, a 57-year-old male with back pain more than leg pain for 10 months. On examination, he had a plantar flexion on the left side 4/5. Rest neurology was normal. Patient had an instability as is shown in flexion extension X-ray. The MRI shows significant canal compression with hypertrophy of ligamentum flavum and effusion at the facet joint. Preoperative JOA score based on questionnaire was found to be 14. Patient was operated using with laminectomy with augmented screws and rods since the patient was osteoporotic, and was followed up for 12 months. Post-operative JOA score at the end of 12 months was 25. However, the plantar flexion remained on the left 4/5. The recovery rate was 78.95%, which was falling in the good category. Based on my study, the results were the patients with lesser duration of symptoms had significant improvement in recovery rate as compared to the pre-op JOA score. Patient with preoperative instability did significantly better. However, patients with neurodeficit did not have significant improvement as compared to those without neurodeficit. However, it is to be noted that none of the patients that were chosen for the study had any functional loss in sensation or power. To conclude my study, patients with pre-op instability and short duration of symptoms before surgery were more satisfied with the surgery, and patients with or without neurodeficit did not have any significant difference in recovery score. So my study suggests that for patients with lumbar canal stenosis, after a fair trial of conservative treatment has been done, it advises patients early surgery, particularly for pre-op instability, so that they have significant improvement in the recovery rate. However, my study has been done on a small scale. The patients included were only 30. So a larger study needs to be done to apply this results of the study to a generalized population. Thank you.
Do we take questions, right? Yeah. Any questions? Yeah.
A good paper, Dr. Pooja.
Yes, sir.
I just wanted to ask you about your indications, because you had classified into 4 categories without PLIF. So both the cases were almost similar with mild instability, having a grade 1 listhesis. So in one you had done a PLIF, the other one you had done only instrumentation without PLIF. So what were your criteria to differentiate or indications for your PLIF?
So for patients with instability, we added instrumentation. The patients we did discectomy with a large protruded disc. For those we did PLIF.
Asking is, what is your indication to do interbody fusion in first case, right, sir? Yeah. And you didn't do the interbody fusion in the second case.
Both showed the instability.
Both showed instability.
You did discectomy, the other you didn't do discectomy. So.
Sir, for first patient, there was significant canal compression with a large disc protruding in the canal. The second patient did not have such a large disc protruding in the canal, so discectomy, a lot of disc material was removed for the first case. So that is why we had to add interbody fusion for that particular patient. We did not need to remove a lot of disc for the second case since there was not significant protrusion. So we just went ahead with instrumentation for that patient.
How long did you follow up the instrumentation case? Only where you did the instrumentation?
So all the patients were followed up for 12 months.
And is there any decrease in back pain in the second case?
So there was significant decrease in back pain since patient also had a lot of instability, pain due to instability. Instrumentation relieved a lot of back pain for both the patients.
Okay.
Thank you. Next talk is by Dr. Nandini Iyer about analysis of current trends in spinal TB with a focus on functional outcomes in MDR TB patients.
Good afternoon, respected Chairperson and all my colleagues. Today I'll be talking about the analysis of current trends in spinal tuberculosis with a focus on functional outcomes in MDR TB patients. A 17-year-old female had presented with complaints of back pain, deformity, and bilateral lower limb weakness since 2 years. She was diagnosed with D10-12 spondylodiscitis, probably due to COX, and started with category 1 AKT empirically at her village in Uttar Pradesh. About 10 months through this category 1 treatment, there was no improvement clinically or radiologically, and she finally presented to us after about 8 months of category 1 AKT in December 2021. A CT-guided biopsy was done, which was found to be positive for Mycobacterium tuberculosis. It was also found to be resistant to all first-line AKT, along with fluoroquinolones such as moxifloxacin and levofloxacin. A diagnosis of extremely drug-resistant tuberculosis had been made after this. However, as per more recent guidelines, cases that are resistant to all first-line drugs along with fluoroquinolones are classified as pre-XDR, and an added resistance to bedaquiline or linezolid is required for a XDR diagnosis. So the patient was accordingly started on sensitive AKT. 5 months through this, she came back with improved neurology, but progressively increasing incapacitating back pain and a deformity which had worsened to now 50 degrees of a Cobb's angle. This was her radiological picture then. She was then managed with surgical intervention, and a complete correction in deformity had been achieved after posterior instrumentation, decompression, and debridement was done. This is her radiological and clinical pictures 3 months through follow-up. And she had achieved full functional recovery and is now able to do all her activities of daily living without the requirement of a brace also, and is completely pain-free. The sensitive AKT that had been started pre-operatively was continued into the post-operative period as well. A 2.5-year-old female had presented with back pain, bilateral lower limb weakness with upper motor neuron signs and deformity. A diagnosis of D8 to 10 spondylodiscitis was made. This child had been started on empirical AKT outside but had defaulted in the treatment, and then she presented to us with worsening neurology. She was managed surgically with a decompression, debridement. This is her intra-op picture, and she was managed with instrumentation using a customized pediatric heart shield along with sublaminar wires that was spanned from D5 to L2 level. Post-operatively, there was a correction in deformity with a complete recovery neurologically, and she was supported on a total body contact brace. The intra-op samples were found to be positive for Mycobacterium tuberculosis with rifampicin resistance, and a multidisciplinary approach was taken along with the consultation of a chest TB physician and a pediatrician, and she was planned to be started on bedaquiline with sensitive AKT for 18 to 20 months. A 15-year-old female had presented to us with back pain and constitutional symptoms. A diagnosis of D10 and L1 spondylodiscitis was made. At that time, the CT-guided biopsy that was done was found to be inconclusive. However, empirical category 1 AKT was started. She had failed to follow up and then followed directly 6 months later with progressive worsening and weakness in bilateral lower limbs and a complete power of 0. Despite 6 months of taking category 1 AKT. And as you can see here, there's a complete collapse in her D10 and L1 vertebral bodies. This patient was then managed surgically with decompression, debridement, and instrumentation, along with 2 cage insertions. And the intraoperative sample was found to be positive for MTB with rifampicin resistance detected. She was started on appropriate AKT for MDR TB in the postoperative period, and this is her functional recovery with on a brace 3 months through follow-up. We conducted a retrospective analytical study at tertiary care centers in the city. 10 patients were selected, all of whom had spinal tuberculosis that was also drug resistant and required surgery. However, patients who did not have any drug resistant tuberculosis and who could be conservatively managed were not included. The surgical principles followed were decompression, debridement, and instrumentation. All of these patients had received sensitive MDR AKT regimen at some point, either initiated in the preoperative or the postoperative period. Immediate postoperatively and on AKT, a functional assessment was done using the Functional Independence Measure score and the Oswestry Disability Index score, with a result of 7 and 0 to 100% being the best outcomes in both. Our results showed that around 8 out of these 10 patients had already been initiated on preoperative AKT, 3 out of whom were started empirically and 2 who were found to be defaulting. A targeted treatment was started post-operatively in 7 out of these 10 patients, and drug sensitivity testing with a 14 drug sensitivity panel was done in 4 out of these 10 patients. 8 out of these 10 patients had received bedaquiline for 6 months. We also found that out of these 10 patients, 8 had done very well functionally on a combined approach with surgery and AKT, with an FIM score of 7 and an ODI score of 0 to 2%. I would like to conclude by reiterating that the gold standard for the treatment of drug-resistant spinal tuberculosis is a biopsy, and I would also like to emphasize that if in the event that the first CT-guided biopsy done comes out to be negative, then attempting repetitive biopsies may be suggested or should be the way forward. And in the event of rising drug-resistant cases, we should consider doing a 14-drug sensitivity panel as far as possible for all patients. If appropriately treated with sensitive AKT for an adequate duration of time and surgery were indicated, most of these patients do end up with good functional outcomes. Thank you.
Any questions?
In such big abscesses, is there any role of doing, instead of CT guided, can we do the biopsy with the J needle in the OR?
Yeah. Anyway, Dr. Nandini, it's a good paper.
Thank you.
There. I think the point she wanted to emphasize is that even though the scenario in which she studied it, that's SAN hospital or a KM hospital, where probably once you ask for a CT guided biopsy, most of the time patient lands up with negative to aata hai, but the appointment, by the time the appointment comes, it's usually 1 month or 6 weeks, or sometimes even I have seen even up to 3 months there. By the time you are giving that much time for the mycobacteria to destroy even further vertebra, so half the times we'll end up with starting empirical AKT, but that's not the end of it. That's why, because a few of the patients, even in my series, also landed up with, in spite of being on empirical AKT, landed up with deficit. And so those 10 to 20% they do are MDR this thing. One question I wanted to ask you is that out of your 10 patients, 3 of them are defaulters.
2 of them are defaulters.
Did you inquire whether they were taking it the proper doses? Because one important reason for developing MDR is the improper doses. You like a weight related, the dosages and everything. It's important.
Right.
So the repetitive biopsy, yes, I think one CT guided fails, you repeat another CT guided. If not, try with a CM guided big bore needle there. And if I'll usually prefer scan the abdomen also, if there are any psoas abscess, if there are paraspinal abscesses, well and good, you can aspirate directly. But if there are any psoas abscess or something, at least we can do an aspiration, the pigtailing or something, and that will give you probably more material there.
Thank you. Thank you, Nandi. The next talk is from Dr. Sushil, the study of correlation between fracture pattern, functional outcome, and pin configuration in supracondylar humerus fracture in children as per Bahk classification.
Good afternoon, everyone. Thank you for allowing me to present in the WIROC MAX 2022. So my topic is about study of correlation between fracture pattern, functional outcome, and pin configuration in supracondylar humerus fracture in children as per Bahk classification. A pediatric supracondylar humerus fracture compromises 3% of all the pediatric fracture and is associated with clinically significant complications such as neurological injury, malunion, and compartment syndrome. Wilkins modified Gartland classification system is most widely used classification system for this fracture, dividing them into 3 types based on their initial fracture displacement. Type 1, there is no displacement, where it is treated conservatively with cast, and type 2A, where there is an intact posterior cortex hinged in extension, no rotation or translation. Type 2B, intact posterior cortex hinged in extension with some degree of rotational displacement or translation. In type 2 fractures, it is usually treated conservatively or managed by surgically with pinning, depending upon the degree of stability. Type 3, there is a complete displacement where it is treated with surgical management by pinning. Bahk et al. In 2008 revised the classification based on a fracture pattern in the coronal and sagittal plane and proposed pin configuration specific to fracture pattern. The Bahk classification is based on the angle the fracture line makes with the line perpendicular to the distal humeral axis. In the anterior-posterior view, this is described as a coronal obliquity, which is greater than or equal to 10 medial oblique or lateral oblique varieties. It is more associated with more combination and rotational malalignment. In the lateral view, it is called a sagittal obliquity, where it is greater than 20. It is high sagittal. It is associated with rotational malunion and also associated with other injuries. These are the sketches of the coronal fracture subtypes. In type A, which is called as a typical transverse fracture, where there is less than 10 degree of coronal obliquity with fracture plane entering and exiting near the epicondyles. In type 2, a lateral oblique fracture where greater than 10 degree of coronal obliquity with proximal fracture plane exiting laterally. Type C, medial oblique fracture where greater than 10 degrees of coronal obliquity with proximal fracture plane exiting medially. In high fractures, a fracture plane entering and exiting above the olecranon fossa but within the distal humeral metaphysis. In sagittal fracture subtypes, in type A, where the low sagittal fracture, where the fracture plane is less than 20 degree. In high sagittal fracture, where the fracture plane is greater than 20 degree. Main aim and objectives of my study are to compare the pin configuration done during close reduction and pinning in type 2 and type 3 supracondylar fracture of humerus in children with the age less than 14 years of age to that suggested by the Bahk classification, and to study the clinical outcome based on the Flynn criteria and its correlation with the concordance of the pin configuration between execution and as suggested by the Bahk classification. Multiple assay method. My study is retroprospective study where total number of 40 patients was used without neurovascular complications. Inclusion criteria, supracondylar fractures without neurovascular complications, age less than 14 years of both sexes. Gartland type 2 and type 3 fractures were used. Exclusion criteria, fracture more than 3 days old, patient type 1 Gartland fracture, open fractures associated with other fractures in the ipsilateral upper lip, patient with history of deformity, contracture or any neurodeficit in the ipsilateral upper limb before the trauma. A functional outcome were based on the modified Clinicoradiological criteria and also the radiological outcome based on the Bowman's angle, the anterior humeral line. The clinical, the pin configuration was determined as per suggested by the Bahk et al. There was 2 lateral pin for the typical transfer and a lateral oblique, and in sagittal view low transfer, and cross pinning for the medial oblique fracture. 3 lateral pin if all the pins, if possible, that all 3 pins are good purchase in the proximal fragment, or 2 lateral pin and 1 medial pin in the high transverse fracture and the high sagittal fractures. These are the some examples where it shows the first image shows the typical transverse fracture where the 2 lateral pins are used. In lateral oblique fracture, 2 lateral pins are used. In medial oblique fracture, cross pinning was done with 2 lateral pin and 1 medial pin. And height transfer fracture, there was 2 lateral pin and 1 middle pin was used. In low sagittal, 2 pins was used, and in high sagittal, 3 pins were used. Observation and result, age distribution of the patient in study. There is the average age group is around 7 years. In gender distribution, in 25 patients were male and 15 patients were female. There was a male predominance. Mode of injury, most of the children came with a fall while playing. Second were the fall from the height, and third of the cycling. Side involved, right side was more involved than the left side. Gartland type fracture, in our series of 40 patients, 16 patients, 40% were affected by type 2, and 24 patients, that is 60%, were affected by type 3 supracondylar humerus fracture. Frequency of fracture type in our study, where typical transfer fracture we observed around 18 patients, lateral oblique 11, and medial oblique 7 patients. High transfers 4, and total of 40 patients, and low sagittal around 18 patients, and high sagittal 22 patients. Distribution of pin configuration, there was 1 lateral pin and 1 middle pin in 3 patients, 2 lateral pin in 10 patients, 2 lateral pin and 1 middle pin in 8 patients, 3 lateral pin in 4 patients out of 40 patients. Distribution of pin configuration as per Bahk classification, where pin configuration as per Bahk et al. Suggested, and what we have done in our study. So in high transverse and high sagittal, it was suggested for 3 lateral pin or 2 lateral pin plus 1 middle pin. We have done 2 lateral pin and 2 middle pin in a 3 patient. In high transverse and low sagittal, it was suggested a 3 lateral pin or 2 lateral pin plus 1 middle pin. We have done 2 lateral pin plus 1 middle pin. In lateral oblique and high sagittal, 8 patients were suggested. 8 patients, we have done 2 lateral pin and 1 middle pin. In 8 patients, out of 8 patients, 6 patients we have done 2 lateral pin and 1 middle pin, and 2 lateral pin, 2 middle pin in 1 patient, 3 lateral pin in 1 patient. Sir. Lateral oblique and low sagittal, 3 patients were done 2 lateral pin and 1 middle pin. In cross pinning, in medial oblique and high sagittal, out of 3 patients, 2 were done 2 lateral pin and 1 middle pin, and 2 lateral pin and 2 middle pin in 3 patients. In medial oblique and low sagittal, cross pinning was done, 1 lateral pin and 1 middle pin. In typical high transverse and high sagittal, 2 patients, 1 patient was done 2 lateral pin, and 2 patients was done 2 lateral pin and 1 middle pin, and 3 lateral pin in 3 patients. Typical transverse low sagittal fracture, 2 lateral pin, so one lateral pin, 1 middle pin in 1 patient, and 2 lateral pin in 10 patients, and 2 lateral pin and 1 middle pin in 1 patient. So we have done 13 patients over fixation, and right fixation was done in 26 patients, and under fixation was done in 1 patient out of 40 patients. Reduction, most of the 39 patients were done in closed reduction, and 1 patient was done in the open reduction. Range of motion was observed for the follow-up of 3 weeks, 6 weeks, 3 months and 6 months, and for range of motion loss at final follow-up was also taken. There is a change in carrying angle, was ranged from 0 to 6 degree, average being 2.35 degree. Change in Bowman's angle was compared at immediate post-reduction, post-union. 27 modified Flynn criteria to evaluate outcome of treatment grading. 27 out of 40 patients had a carrying angle loss of 0 to 4.9 degree, which was considered to be an excellent result. 10 patients had a 5 degree to 9.9 degree, which was considered to be a good result. 3 patients had 10 to 15 degree, which was considered to be an fair result. Majority of our cases had an excellent result and good. All patients shows Flynn criteria satisfactory. Complications, out of 40 patients, there were 3 patients were superficial pin tract infection was present, and 3 patients there was a pin insertion ulnar palsy which was recovered within 3 months, and 1 patient with a cubitus virus deformity. Rest other or good. Conclusion of my study is the present study shows that type 2 and type 3 displaced supracondylar humerus fracture in children can be underfixed or overfixed if the Bahk classification is not applied. The knowledge of Bahk classification helps in optimum pin configuration and fixation for management of this fracture. this article. Thank you.
Any questions? Thank you. The next talk is by Dr. Ahmad in Clinicoradiological Predictors Determining Outcome in Spinal TB.
Hi, good afternoon. This talk is basically about clinicoradiological predictors determining the outcome in spinal tuberculosis. So it's basically a pool of 60 patients done a prospective study between 280 and 220. Half of them underwent conservative treatment, the others went surgery. Basically every patient went into a physical exam, we did neurological exam. We looked into the presenting symptoms, functionality, and VAS scores. We used multiple ways to assess this. And after treatment, we followed up with the patients over an interval of time of 6 weeks, 3 months, 6 months, and 1 year. And we also looked into the radiological aspect, looking for destruction, involvement of multiple vertebrae, and looking for any changes along the way. So we included all patients with dorsal and lumbar involvement, all ages. Pregnant patients were removed. Patients with cervical involvement were removed, along with any other spinal tumors. What took us into conservative treatment? Basically patients with no spinal instability, no massive kyphosis or deformity. We chose operative for patients who have neurologic complications, who have failed conservative treatment, some kind of an active infection, or progression of symptoms or neurological problems. So what did we observe? We observed that the prevalence is mostly the first 3 decades of life. Males and females do not make a difference. Functionality, basically we took the majority of patients with a functional first onset, and after treatment we see that every patient became completely functional. On the other aspect, surgical patients were picked out, the ones who are non-functional, and we did have a huge improvement in the results and the functionality of most of our patients. When it comes to neurology, we can see that the patients who went to conservative treatment resolved completely with an E, given E as neurological symptoms or signs. For the surgical patients, lots of improvements, statistically significant, but there remains a few patients who did not make it to with better neurology. Cobb's angle, statistically insignificant increase in Cobb's angle, 0.1 degree for conservative patients, but on the other half, the operative patients, a major decrease in Cobb's angle post-surgery from 27 degrees to 14 degrees. The ODI, similar to the VAS score, completely shows an improvement for both pools of patients, the conservative and the surgical. These are the complications on both pools of patients. So there has been older similar papers done before, and they all showed the same results, that whatever you do, patients will improve. The main thing is to start the therapy, make it medical or surgical. What we're trying to do in this topic here is trying to find out the factors that we should look at to optimize the treatment. As long as you start the treatment with the anti-TB management, then you're on a good track. Some patients need more help and more aggressive therapy based on specific factors. We have realized that there are limitations to this study. First is that each patient came with different onset of symptoms, which might have been a bias since lots of the symptoms are subjective. And we use all posterior fusion instrumentation in all our patients, so we can't really differentiate between different types of surgical approaches. So in my conclusion, based on this paper, there has been lots of other new papers followed, especially from the Japanese side, talking more about in details about these 6 points, how to use them to assess clinically if you're taking your patient into the OT or not. So first is an age. Some are discussing under 8 years or under 15, which you should have a bit of a less of a tendency for surgery, especially if you have a high kyphosis over 30 degrees. And we have seen that in this paper. VAS, if it's not getting better, even 4 to 6 weeks after conservative treatment, maybe it's a good candidate for surgery. Radiological instability, listhesis. Similarly, radiological destruction, involvement of 2 or more vertebrae. Posterior involvement causing instability is also something you should take into consideration. Neurology, again, watching the patient, keeping up, following up a few weeks after treatment. If there's no improvement, you go for surgery. Thank you.
Any questions for this? That's it. Thank you.
Good afternoon, everyone. So my topic for today is a prospective observational study of pin tract infection in external fixation from a tertiary healthcare center. So it is already well established that pin tract infection is the most common complication of external fixator use. So the prevalence of pin tract infection as per published literature is anywhere around 20 to 30%. But due to a lack of universally accepted definition and methods of reporting, there are discrepancies in reported versus true cases. The risk factors for these infections can be divided as patient factors and surgical factors. Patient factors such as age, comorbidities, type of wound, etc. And surgical factors such as pin insertion techniques, pre-drilling, pre-tapping, etc. These infections have a wide range of complications that can go from minor complications like redness, erythema, wound discharge, to major complications like necrotizing fasciitis, osteomyelitis, and toxic shock syndrome. The objectives for the study was to identify the prevalence of pin tract infection, to identify the grades of pin tract infection, also the risk factors and outcomes of these infections. This was a prospective observational cohort study that was undertaken in the Department of Orthopaedics at Bharti Hospital, a tertiary healthcare center and teaching institution in Pune. This was a 2-year study which was from October 2020 to October 2022 and included a total of 22 patients and 112 pins. We included men and women between 18 to 70 years of age, emergency and elective surgeries both, all type of frame constructs and all long bones. We also included both open and closed fractures for the study. We excluded Elizarov ring fixator and Taylor spatial frame from the study. And the frequency of data collection was day 1, day 3, day 7, 3 weeks, 6 weeks, 3 months, and 6 months if required. The classification for pin tract infection used for this study was the Checkett-Otterburn classification, which basically divided pin tract infection into 6 grades. The first 3 being minor infections and 4 to 6 being major grades of infection. And the basic differentiation between these 2 grades was that for major infection, the external fixator had to be abandoned. Grade 1 infection is slight redness and a little discharge which settles with dressings. Grade 2 is associated with soft tissue tenderness but settles with a short course of antibiotic. In grade 3 infection, the pins need to be resited. Grade 4 infection is associated with multiple pin loosening and the external fixator has to be abandoned. Grade 5 infection has radiographic features of osteomyelitis, and grade 6 infection is what occurs after removal of the external fixator, where there's skin breakdown and formation of sequestrum. Coming to the observational and results, so the mean age for the patients was 49.7 years, and there were 16 males and 6 female patients included in the study. 3 patients were diabetic, 3 hypertensive, and 4 had other comorbidities. The sites for pinning was 6 patients with an isolated tibia fracture, 6 patients with delta frame which included pinning of the tibia and calcaneum, 1 patient for femur plus tibia, 5 proximal humerus, and 4 radius and first metacarpal. 10 of the patients had closed fractures and 12 were compound fractures, the most common being compound grade 2 and compound grade 3B, which were 4 patients respectively. 9 patients had a uniplanar fixator, 6 had a delta frame, 5 UMEX, 1 biplanar and 1 hybrid. So out of the 22 patients, 21 had some grade of infection, and the rate of pin tract infection found was 45.5% with a total of 51 pins out of 112 that were infected. All the infections were minor and the X-fix did not have to be abandoned for either of these patients. The rate of pin tract infection in the calcaneum was 100%, which is all 6 of them that were infected. 47.5% for the tibia, 40% for humerus, 40% for radius, and 10% for first metacarpal respectively. These are just some clinical pictures of the grades of infections that we can see. The rate of infection also varied by frame from 5% to 35%, the most common being the uniplanar and delta fixator. All the pin site infections resolved with the use of antibiotics except for 1 patient with a minor grade 3 infection in whom the external fixator was removed and amputation was performed, not for the pin tract infection but for reasons relating to the original wound state, which was a compound grade 3B wound. There was a significant positive correlation reported between the number of pin site infections and the duration of external fixator in weeks. There was no significant correlation found between the number and grade of pin site infection, type of wound, duration of antibiotic cover, compliance with home dressings or any other factors. So coming to the take home message is that the rate of pin tract infection was around 45.5% as per the study. All the infections were minor grade. Almost all the calcaneum pins were infected. And the only positive risk factor identified for infection was the duration of external fixator and comorbidities of the patient, type of wound, duration of antibiotic, type of pin used, or compliance of the patient with home dressings had no bearing on the rate of pin tract infection. I'd also like to highlight some limitations of the study. The first limitation is the sample size, which is 112 pins but only 22 patients, which is relatively small. And also we have included both closed and open fractures in the study. So those are the 2 limitations. Thank you.
Thank you. Dr. Pooja.